study. Thank you.
Hello, thank you so much for having me. I am here on behalf of one of my mentees, Arlene Delgado, who is a pediatric resident about to go into pediatric GI, who could not make it because of current conditions and the fact that she is not a US national. But she has done extraordinary work looking at outcomes data in GLP1 use in using a large-scale data set called Trinetics. So I do have some disclosures, nothing that's specifically relevant to this talk. So Dr. Delgado got really interested in this, and she came to me as a research mentee because she's fascinated by the impact of metabolic disease in her community, and particularly Hispanic immigrants in the United States, but also in the global South more broadly. She had noted this broad increase in risk and increase in things like liver transplantation in children in the United States and adults in the United States from MASLD, and really was interested in the impact of one of the largest new most impactful new drug classes we've come up with recently, the GLP1 receptor antagonist, on this population, and in particular, some of the associated risks that you see with MASLD in children. So MASLD, if you are unfamiliar, which I doubt many of you are, is the most common chronic liver disease in pediatric populations. It progresses to inflammation and fibrosis, can eventually to cirrhosis, and for a while had been the largest increasing cause of liver transplant in the United States, although I suspect that trend is going to reverse itself. It is linked with a lot of psychiatric comorbidities, both in adults and children. And so there is a direct linkage that suggests some possible causality of having MASLD to create anxiety and depression, although of course, the causal linkage is a little bit hard to impute. What are GLP-1 receptor agonists? Well, they are medications that recapitulate a naturally produced product from the most important organ in the body, the intestine. And sorry for the hepatologist in here. The medication has a variety of different effects, but there are several different ways in which it might impact MASLD. The most obvious would be the weight loss effects. So if you are no longer depositing adipose tissues in your central region and not having more fat depositing into your liver, you will lose some of those concerns. However, there are other benefits. There are anti-inflammatory effects that have been observed, including things like adult trials showing a decreased risk of asthma exacerbations in these patients that is happening prior to weight loss. There are other evidence of anti-inflammatory effects from GLP-1s broadly. There are direct effects on liver remodeling that can be observed in vitro studies. And then there is the possibility of neuropsychiatric potential. There are GLP-1 receptors in your brain, and they do control things like addiction circuits and other related processes that can control behavior. So there's a lot of reasons to suspect that maybe GLP-1s are having some benefits in mental health beyond just the fact that they are helping people feel better about themselves or other issues like that. So what do we do to look at this? Well, when you're looking at sort of a broad hypothesis, one of the things I work with our trainees on is using the right data set. So we looked at Trinetics. Trinetics is a mainly US-based data set that uses real-time non-PHI data from EMRs around the country. Covers about 170 million people at this point, individual patients, but it gives you a very large set of people to look for patterns, and that's what we tried to do with this. So we looked at the population of 206,418 patients aged 12 to 21 who had both obesity and MASLD, and these were based on ICD-10 diagnoses. And then we looked at folks who have been on semaglutide, liraglutide, dulaglutide, tirzepatide, and exenatide as the exposure. And we kind of had to include all those groups to make sure that we had a large enough group to find, a pattern. And what I want to always say about use of data like this is that there's a lot of caveats, and you should be looking at this as a trend, not a definitive, this is the exact effect. So then we did a logistic regression with raw and propensity score matched cohorts, and here were our results. So unsurprisingly, I think some of the strongest results are in things that have addiction circuits, which makes sense biologically because the GLP-1s should, in fact, stop that effect. So you see major improvement in things like drug use, alcohol disorder, and vaping. And we look at a non-MASLD population, you actually see that most of these become significant and do not cross 1. What we saw that was significant in this population was improvements in depression, an improvement in suicidal ideation, and an improvement in vaping, as well as nicotine dependence. All these things tended to trend positively with the exception of eating disorders, which is probably unsurprising given that one of the side effects of this medication would qualify you for a diagnosis of an eating disorder in many patients. So this is, again, really positive, and particularly the reduction in suicidal ideation of 46% gives you just a lot of reason to suspect that we're probably not just looking at someone having an improved interaction with the world around them, with people being more kind or better mental health about self-image, there probably are some underlying effects here, because the things that are really driven are the biochemical aspects. We can really see that it's the addiction behavior and the behavioral choices that seem to be improving the most, as well as signal towards improvement in ADHD, which is even stronger in the non-MASLD group. So we had some theories about what we think might be doing this, which is mainly just that there are a couple different, likely multifactorial improvement that you get from being on these medications. The world will treat you more nicely. Sadly, there is bias against folks who carry more weight in most parts of the world. You will end up having improvements in neuromodulatory effects for dopamine and serotonin pathways. You can have a sign that there's antidepressant effects. There's increasing linkage of inflammation as a causal mediator in depression and anxiety, not just a secondary effect of it. And then there also just might be secondary impacts to reward circuitry and other things that create a feeling of well-being that mitigates these issues. So as I mentioned before, the use of trinetics does have a lot of flaws. We are stuck with whatever folks have documented, so we are stuck using ICD-10s. There can be misdocumentation, there can be incorrect assessment. Trinetics has some issues in terms of what data you can call, and we do not have access to the discrete patient records, so we cannot validate as clearly. So this is really more of a kind of like RNA sequencing tool to identify patterns and look at things that are interesting for more appropriate prospective or retrospective study at a higher level of granularity. And then the other thing is we do have variable treatment. The statistical methods we used did attempt to control for this, but we don't know exactly from the Trinetics data set how long people have been on things. While we are able to go back several years due to the large group of drugs that we used, you are still a little bit constrained in terms of being absolutely confident in the numbers. So I would say that this is mainly something that points towards a very nice demonstration of benefit, but not giving you the exact numbers of how much. So what we'd like to do in the future is consider an RCT, look at biomarkers, consider possible neuroimaging, because I think this could actually be interesting to look at fMRI in these patients, and then long-term studies to see if these effects are durable, if they are short-term, and to correlate whether or not this is happening linearly with weight loss or whether this is happening independently through biochemical effects. And so these are our conclusions and our references. And any questions?